Welcome back, guys, for part 2 of the final step for our PANCE studying here. So we left off in the neurology section. So we started off with orthopedics. Most of it was orthopedics anyways, and now moving to the middle of neurology now. So we just finished up with the abortive drugs for migraines. Like we said, triptans, ergotamines. So now, next one is an EEG showing focal rhythmic discharges at the onset of the seizure. Should make you think of what diagnosis? Focal, importantly, focal rhythmic discharges. That's going to be a simple partial seizure. So simple partial seizure. And remember, the ones that are partial are also focal. Okay, what is the single most important thing to be concerned about in a patient with status epilepticus? So status epilepticus, what do we want to be concerned about? That's going to be, of course, the airway. We need to protect their airway, followed by management of the hyperthermia. Okay, and what do we treat status epilepticus with? So what is the first line for status epilepticus? So first line, you want to give a benzo. You can do IM midazolam, or you can do lorazepam as well. And what do you do if that doesn't work? What's your next line treatment? They'll often give you, okay, if we tried benzo, but it didn't work, what's the next line agent? Then you can give phenytoin or phosphenotoin, or you can give levetiracetam as well. And if that doesn't work, the third line, I believe you can do phenobarbital as well for that, or propofol. So describe the Brudzinski's sign. So what is the Brudzinski's sign? This is when you lift the patient's head and the patient bends his hips. So he's bending his hips to compensate as well. So Brudzinski's sign, bending the head and bending the hips, lifting the head and bending the hips. Name the 3 medications used to break a seizure. So this is exactly what we said in status epilepticus. Diazepam, lorazepam, or IM midazolam, and phenytoin or phosphenotoin is the second line after these don't work. So there's an MRI result of a multifoci of demyelination in the white matter. What's the most likely diagnosis? So multiple foci of demyelination of the white matter. What's the most likely diagnosis? Multiple sclerosis. So those myelin sheaths, we're losing those myelin sheaths. So that's demyelination, and there's multiple sclerosis of that. You can see that in MRI. List the 3 medications used to treat multiple sclerosis. So steroids for an acute exacerbation, like IV methylprednisolone, interferon beta, and copolymer 1. So steroids, interferon beta, and copolymer 1 for multiple sclerosis. What's the most common cause of dementia? So what is the most common cause of dementia? That's going to be Alzheimer's disease, and it may be as high as 80%. So Alzheimer's is about 80% of all dementia is Alzheimer's. And what are some other causes of Alzheimer's? Or what are some other causes of dementia anyways? So Alzheimer's, most common at 80%. Can also be vascular dementia. It could also be, which is after repeated strokes in a stepwise fashion. They're declining in a stepwise fashion for multiple microinfarcts over time. There could also be Lewy body dementia, in which they're having visual spatial abnormalities, and it also kind of looks a little bit like Parkinson's disease. They could have frontotemporal dementia as well, which is a more early onset, and they have things like hypoorality, extreme behavior changes, and that happens in like 50s to 70s. So those are some of the other common causes. However, Alzheimer's disease, the most common cause by far. What 4 chromosomes have been linked to dementia? So what 4 chromosomes are linked to dementia? 1, 14, 19, and 21. I've never seen that question asked, but 1, 14, 19, and 21 are 4 chromosomes involved in dementia. So is the ankle jerk reflex of lumbar or sacral origin? So the ankle jerk reflex, so the Achilles reflex, the ankle jerk reflex, lumbar or sacral origin, and that's going to be sacral. So remember, S1 goes down the back of your leg and to the lateral aspect of your foot. L5, the middle of the foot. L4, the medial aspect of the foot. So L4 is more the knee jerk reflex. The ankle jerk reflex is going to be S1. And L5 doesn't really necessarily have a direct reflex associated with it. A study result comes back with intracellular neurofibrillary tangles and extracellular neuritic plaques. What is the most likely diagnosis? So we just said intracellular neurofibrillary tangles and extracellular neuritic plaques. What's the most likely diagnosis? That's going to be Alzheimer's disease. So always associate neurofibrillary tangles and neuritic plaques with Alzheimer's disease. So a patient complains of an aching headache, which feels like a band around his head. What's the most likely diagnosis? So aching headache, a band around his head, or a vice grip headache. That's going to be a tension headache. A patient presents to your office complaining of a tremor in his right hand. He states that after a beer, it goes away completely. What's the most likely diagnosis? So we alluded to this earlier. He's having a drink of alcohol, and he has a tremor. So this is a benign essential tremor or a familial tremor. So what's the difference between this and Parkinson's? The tremor for Parkinson's. Parkinson's is a resting tremor. This is an action tremor. So he has a tremor in his hands. It's an action tremor, and after he takes a beer, it goes away. And you can also use propranolol, like we said, for this. And it's differentiated from Parkinson's because Parkinson's is a resting tremor or a pill-rolling tremor. List 2 medications you might use to treat an essential tremor. So like we said, beta blocker, which is propranolol, and also primidone. So sometimes they'll ask for that second-line agent, primidone, for essential tremor. At what age do Huntington's disease symptoms appear? So at what age do Huntington's disease symptoms appear? So that's going to be around 30 years old. And remember, this is that autosomal dominant condition with the chorea, and that's Huntington's disease around 30 years old. So a 35-year-old patient comes to your office because his wife made him. He has increasingly been irritable and moody. She notices also that he is very restless. You order a CT, which shows cerebral atrophy, as well as atrophy of the caudate nucleus. What's the most likely diagnosis? So that's, again, Huntington's disease. So caudate nucleus in Huntington's disease, and like we said, decreased substance P, as well as decreased GABA in the caudate nucleus. And we're also seeing atrophy here, cerebral atrophy. Very restless, so that's that kind of signifies the chorea of Huntington's disease, those abnormal movements. And he's also 35 years old. So a lot of indications here for Huntington's disease. What medication is the treatment of choice for Tourette syndrome? That's going to be haloperidol. So haloperidol for Tourette syndrome. A slit lamp test shows Kaiser-Fleischer rings. What's the most likely diagnosis? So Kaiser-Fleischer rings in a slit lamp test, so that's in the eye. What's the most likely diagnosis? That's Wilson's disease. So those are those classic like yellow, blue, green rings around the eye, and those are Kaiser-Fleischer rings, and that's pathognomonic for Wilson's disease. And it's due to decreased ceruloplasmin. So that's often asked too. Decreased ceruloplasmin is not allowing you to get rid of the copper. So you're having too much copper accumulation, and you can even see it in the eyes with the Kaiser-Fleischer rings. That's Wilson's disease. Okay, so right here, Wilson's disease is associated with a buildup of what mineral? Like we said, Wilson's disease, deficiency of the copper binding protein, ceruloplasmin, and therefore a buildup of copper. So therefore a buildup of copper. And what's the treatment of Wilson's disease? So we have a nice mnemonic for the treatment of Wilson's disease. So what's the treatment of Wilson's disease? I remember that as TZD6. So it's trientine, zinc, D-penicillamine with pyridoxine, vitamin B6. So TZD6, trientine, zinc, D-penicillamine with vitamin B6. And what are the genetic characteristics of Wilson's disease? So genetically, it's autosomal recessive, and it's on chromosome 13. So chromosome 13, decreased ceruloplasmin, which helps bind the copper away. So we have a deficiency in that. We treat them with TZD6. What cranial nerve is affected with Bell's palsy? So Bell's palsy, what cranial nerve is affected? That's going to be cranial nerve 7. So Bell's palsy, cranial nerve 7, the facial nerve. And how do you differentiate from Bell's palsy and a stroke? So just by looking at their face, patient comes to the ER. How do you differentiate if it's Bell's palsy or a stroke? So a stroke will only affect the eye and below. So they'll still be able to shrug their or wrinkle their forehead. For Bell's palsy, they won't be able to. So Bell's palsy is a complete palsy of that whole cranial nerve, the facial nerve, so they won't be able to do that. And that's how you can help you anyways differentiate between a stroke and Bell's palsy. So a lumbar puncture for a patient with bacterial meningitis will show elevated or decreased white blood cells, glucose, and protein. So what do we find on a LP with bacterial meningitis? So important to know bacterial meningitis. So it's going to, of course, have elevated white blood cells because it's bacterial. It's going to have decreased glucose because the bacteria are eating up the glucose. So decreased glucose and elevated protein. So important to know for bacterial meningitis, elevated white blood cells, decreased glucose, and an elevated protein. What if it was a viral? What specific thing would you see, cell type would you see if it was a viral meningitis on LP? So we would see a lymphocytosis. So we would see a lymphocytosis in viral meningitis. What symptom is associated with a classic migraine? So what symptom is associated with a classic migraine? And that's just going to be having an aura. So auras are associated with a classic migraine. Elevated circulating acetylcholine receptor antibodies should make you think of what diagnosis? So acetylcholine receptor antibodies make you think of what diagnosis? It's going to be myasthenia gravis. So antibodies against acetylcholine receptors, therefore we can't transmit the acetylcholine across the neuromuscular junction, therefore we can't contract the muscles, so they're going to have muscle weakness in myasthenia gravis. Duchenne's and Beck's muscular dystrophy have what genetic characteristics? So Duchenne's and Becker's muscular dystrophy will have what characteristics? So it's going to be X-linked recessive. So X-linked recessive, importantly, for Duchenne's and Becker's muscular dystrophy. And what sign do we see importantly when the patient is trying to stand up, but they're having to push off their feet, push off their knees, and push off their thighs to even stand up? What sign is that called for Duchenne's muscular dystrophy? That's going to be Gower's sign. So Gower's sign for Duchenne's muscular dystrophy. And that's X-linked recessive. At what age range does Duchenne's muscular dystrophy arise? That's going to be 3 to 5 years old for Duchenne's muscular dystrophy. An EEG shows generalized spikes and associated slow waves should make you think of what diagnosis? So generalized, importantly, generalized, not focal, spikes and associated slow waves. This is going to be a generalized or an absence seizure. So absence is the 3 Hertz spike and wave pattern, absence seizure. And what's the treatment for absence seizure? Absence seizure treatment is going to be ethosuximide, and that mostly happens in kids. So you want to give ethosuximide for absence seizure. And generalized seizure is going to have generalized spikes and slow waves. What's the most common primary intracranial neoplasm? Most common primary intracranial neoplasm, that's going to be a glioma. So most common primary intracranial neoplasm is glioma. What is the most common cause of a subarachnoid hemorrhage aside from trauma? So we already stated this somewhat earlier. A ruptured cerebral aneurysm, a Berry aneurysm, or a saccular aneurysm. A ruptured aneurysm in the brain is a cause of subarachnoid hemorrhage. What are the most common primary cancer sites that metastasize to the brain? So that's going to be the lungs, the breast, and the kidneys metastasize to the brain. Lungs, breast, and kidneys are the most common areas, most common primary cancer sites. So if you have a cancer of this area, that's going to be more common to metastasize to the brain. A resting or a pill rolling tremor should make you think of what diagnosis? So resting or pill rolling, importantly, tremor, should make you think of what diagnosis? That's going to be Parkinson's disease. So Parkinson's disease, pill rolling tremor. Also shuffling gait as well, and postural instability. Weakness and numbness in the left hand might be a blockage in which carotid artery? The right side. So because it's going to the right side, that side controls the opposite side, so you're having the right hand. The left hand for the right carotid artery, or vice versa. A patient has an intracranial neoplasm causing auditory illusions olfactory hallucinations, and emotional changes. What lobe is the lesion likely in? So, intracranial neoplasm causing auditory illusions, olfactory hallucinations, and emotional changes. What lobe is it likely in? That's going to be the temporal lobe. So, temporal lobe. If you're looking for lesions associated with multiple sclerosis and you order an MRI, what do you order, gadolinium or without? You order it with gadolinium. So MRI is better for MS if you order it with gadolinium. What is the defining symptom of Alzheimer's? So what is the defining symptom of Alzheimer's? That's going to be progressive memory loss or memory impairment. So over the years, they're going to progressively lose their memory. Which nerve root is responsible for the knee jerk reflex? Which nerve root is responsible for the knee jerk reflex? And we already alluded to this again, L3 and L4. An EEG showing interictal spikes would make you think of what diagnosis? So EEG, interictal spikes, would make you think of what diagnosis? That's going to be complex partial. And do we lose consciousness with complex partial, or do we retain consciousness with complex partial? So complex partial, we're going to lose consciousness as well. And it has interictal spikes on EEG. And also, what kind of paralysis is it called if they have symptoms after? Postictal symptoms. Paralysis, postictal symptoms, that's called Todd's paralysis. Which is the most commonly herniated vertebral disc? So it's most common to herniate L4 and L5, followed by L5 and S1. So I always thought that L5 and S1 was the most commonly herniated because it was the gap between the mobile lumbar spine and the sacrum, which is more fixed. However, L4 and L5 is more common. But you would think L5 and S1 due to the mobility of the lumbar compared to the sacrum. What are 3 symptoms that are classically associated with normal pressure hydrocephalus? So that's gait disturbance for normal pressure. So normal pressure hydrocephalus, gait disturbance, dementia, and urinary incontinence. Gait disturbance, dementia, and urinary incontinence. So I remember that was CUA as well. Cognition, urination, and antalgic gait. So gait disturbances, cognition, dementia, and urinary, CUA. A patient presents with inability to speak and right-sided weakness. So inability to speak and right-sided weakness. He also seems to understand speech and follows commands well. What type of aphasia should you be thinking of? So like we said before, he understands is okay, so his comprehension is okay. So it's not Wernicke's, it's Broca's, because he has broken speech. It is the inability to speak. And also think about that right-sided weakness. So the Broca's area on the left side. Alcohol might be a major factor in which type of encephalopathy. So alcohol may be a major factor in which type of encephalopathy, and that's Wernicke's encephalopathy. And so what do we give if we presume an alcohol withdrawal? What do we want to give? We want to give vitamin B1, thiamine, to prevent against Wernicke's encephalopathy. A patient complains of muscle weakness and fatigability that improves with rest. Weakness and fatigability that improves with rest. What's the most likely diagnosis? So myasthenia gravis. So myasthenia gravis improves with rest. So what would it be if they had muscle weakness and fatigability that got better with more action? So they had this muscle weakness and fatigability, but more action got better instead of resting. Then you would think of Lambert-Eaton myasthenic syndrome, so LEMS. So you think of LEMS if it gets better with more action, and if it gets worse with more action, you want to think of myasthenia gravis. So myasthenia gravis gets better with rest. Lead pipe or cogwheel rigidity should make you think of what diagnosis? Lead pipe or cogwheel rigidity should make you think of what diagnosis? That's Parkinson's disease. So a patient presents following a seizure. Just before the seizure, she remembers seeing flashing lights, all around her. What diagnosis should be at the top of your differential? So this is complex partial. So complex partial, she's having this aura prior to her seizure. How long does a panic attack typically last? So panic attack typically lasts 10 to 20 minutes. What type of hallucinations are most common in schizophrenia? Auditory, visual, or olfactory? So most common hallucinations in schizophrenia are going to be auditory hallucinations. So auditory, most common type of hallucinations. And those would be hearing voices. What causes anorexic patients to have osteopenia? What causes anorexic patients to have osteopenia? So this is going to be a decrease in estrogen. So remember, estrogen is protective. That's why sometimes we can even give hormonal contraceptives for osteopenia, which helps protect the bone. So if we decrease estrogen, they're going to have a risk of osteopenia. And also it's important to know, what's the female athlete triad then? So female athlete triad, anorexia or eating disorder, osteopenia as well, and amenorrhea. So anorexia, osteopenia, and amenorrhea. Anorexia or other disturbance in eating, in which you have more expenditure of energy as opposed to calorie intake. So when treating psychiatric patients with benzos, are benzos used more commonly in acute or chronic? So acute. So of course with psych patients, we don't want to use benzos as a chronic medication. So we want to use them acutely. What is the most common precipitating event for post-traumatic stress disorder in women? So the most common precipitating event for PTSD in women is rape. A patient's wife complains that he is hypervigilant and also has a hyperstartle response. What is the most likely diagnosis? So hypervigilance, you want to think of PTSD right away. So a hyperstartle response and hypervigilance, you want to think of PTSD, post-traumatic stress disorder. Are patients with specific phobias aware they are strange? Are patients with specific phobias aware that they are strange? And the answer is yes. So they are aware of this. So a patient complains of having a suddenly developed stage fright. So they have stage fright suddenly. It's very important to his career that he's able to speak in front of other groups. What medication might you give him? So if they're having social anxiety disorder such as this, where they're scared to get in front of other groups of people and do something, you want to give them propranolol. So beta blocker to take before they go up there. So beta blocker, propranolol especially, for social anxiety disorder. A donut-shaped burn should make you think of what issue? So a donut-shaped small burn should make you think of either abuse or child or elder abuse. Probably getting burned by a cigarette or some kind of lighter or something. What is a generic name for Prozac? Fluoxetine. So what's about fluoxetine? What's the important thing about fluoxetine? It can be used in bulimia. So fluoxetine is the SSRI of choice in bulimia. So how I remember that is fluoxetine has a U in it and bulimia has a U in it. So fluoxetine, it's a little bit longer acting, so it's the SSRI of choice in bulimia nervosa. And it's also called Prozac. So how long must symptoms last before diagnosing attention deficit disorder? So ADD, attention deficit disorder, has to be 6 months. And you also have to be a few other criteria for this. You have to be in at least 2 settings. So for instance, school and home. You have to at least be under 12 when the symptoms start, as well as 6 months of having them. So 6 months, 2 settings, under 12 the symptoms must start. A patient's mother has recommended that he see you. He lives on his own and is a computer programmer. He works from home. He has no friends and seldom leaves the house. She is concerned that clearly he would like to meet people, but he is terrified to do so. What's the most likely diagnosis? So these are always tricky, but he's terrified to meet other people, so you want to think of avoidant personality disorder. So you might think schizotypal, you might think dependent personality disorder maybe. So schizotypal may be on the differential, but this is avoidant personality disorder. A 6-year-old boy seems to have all the symptoms of ADD while at school, but at home he has no problems. So this is similar to what we already said. So at home he has no problems, so he's only having it in one setting. So therefore, he does not have it. So it must be in both settings for the diagnosis, or 2 or more settings. How about an 18-month-old is not yet speaking? He does not also point to objects, and he also does not make eye contact with others. So what's the most likely diagnosis? So that's going to be autism. So autism, typical of not speaking, not pointing to objects, and also doesn't make eye contact with mom or others. So what screening test do you do for autism? So you do the MCHAT for autism. You do the MCHAT for autism at how old? 18 to 24 months. So at 18 and 24 months, you can do the MCHAT, and then you can also refer them, if there's positivities on those, to a more definitive diagnosis. List 3 positive symptoms in schizophrenia. So list 3 positive symptoms of schizophrenia. So that's going to be things that are added to the behavior, as opposed to negative symptoms would be things like withdrawal from your normal behavior. So added things to the behavior would be such things as hallucinations, whether it be auditory, gustatory, visual hallucinations, could be delusions, as well as movement disorders. So these are things that are all added to the behavior, and these are the positive symptoms in schizophrenia. And also for schizophrenia, what makes it a better prognosis or a worse prognosis? Do positive symptoms make the prognosis better, or do negative symptoms make the prognosis better for schizophrenia? So for schizophrenia, positive symptoms are a better prognosis. I remember that because you can always dull down the positive symptoms, but if they're having negative symptoms, it's kind of hard to bring them back up to normal. So when is the typical onset of Tourette syndrome? 3 to 8 years old. So Tourette syndrome typically comes from 3 to 8 years old, and also rarely past 18 years old. So 3 to 8 years old, Tourette's typically starts. This is a good one. Is anorexia egosyntonic or egodystonic? What about bulimia? So anorexia is egosyntonic. So this is in line with what their mind thinks about them. So they think this is good for them, maybe. They think this is in line with what their body image should be. So that's anorexia. Whereas bulimia is egodystonic. So on some level, they don't want this, but they feel compelled to do this, or it's not in line with what they view themselves as. So egodystonic for bulimia, and like we said, the treatment for bulimia, fluoxetine. And for anorexia, egosyntonic. And anorexia is pretty bad. Anorexia is bad. Anorexia is the highest mortality of all psychiatric conditions. So anorexia, high mortality, however, egosyntonic. And also so we all obviously want to refeed patients with anorexia. And what electrolyte abnormality is at risk for these patients when we're doing refeeding for anorexia? Because they have such a low BMI, so we need to refeed them. But they can also have risk of hypophosphatemia. So hypophosphatemia is classically associated with refeeding in anorexia. Okay, so list 3 cluster A personality disorders. So what's in the cluster A personality disorders? So this is going to be the quote-unquote mad personality disorders. So schizoid, schizotypal, and paranoid. So schizoid, schizotypal, and paranoid. So classically schizoid, you think avoid. So schizoid, avoid. So they avoid people, and they're very to themselves. Schizotypal characteristically has that magical quote-unquote thinking. So schizotypal has the magical thinking. And paranoid is just extremely paranoid. So those are cluster A. How long does menstruation need to be absent before secondary amenorrhea can be diagnosed? So how long does menstruation need to be absent before secondary amenorrhea can be diagnosed? So if they had cycles previously, then it's going to be 3 months. If cycles have been previously irregular, then then it has to be 6 months. So if they were normal, then 3 months. So they were having them every month and then they stopped. We need to wait 3 months before calling it secondary amenorrhea. But if they were previously irregular, that's 6 months of irregular cycles, of no cycles. So a 16-year-old has just moved schools. He is quiet, moody, and not like himself at all. Within 6 months, he seems to have completely changed back to his previous personality. What's the most likely diagnosis? So most likely diagnosis, importantly, they said 6 months, he seems to have completely changed back to his previous personality. So that's going to be adjustment disorder. They change back within 6 months. So you have a patient with a major depressive disorder. Once his symptoms have completely resolved, how long should you continue treatment? So you got better, you gave him an SSRI. The SSRI takes 4 to 6 weeks to kick in, and you got better after a long time. So you still want to wait and still treat for 6 months of a minimum due to the very high relapse rates of depression. What medication is often used to treat postpartum depression in a woman who is breastfeeding? So that's going to be sertraline, Zoloft. So sertraline, another SSRI, and you can give them to postpartum depression patients. So a patient is very strange, magical thinking. What is the most likely diagnosis? So magical is going to be schizotypal. So magical, schizotypal personality disorder. So that was, again, a cluster A personality disorder with the paranoid as well as the schizoid. So schizoid, schizotypal, and paranoid. And schizotypal is magical thinking. Okay, list the 4 symptoms of serotonin syndrome. Okay, 4 symptoms of serotonin syndrome. They're going to be hyperthermia, very importantly. Also seizure, mental status changes, and tremor. They can also have diarrhea too. So what other syndrome, importantly, can lead to serotonin syndrome? Like, how would you even get serotonin syndrome? Perhaps overdosing on a serotonergic drug, of course, like an SSRI, SNRI. How about a serotonin secreting tumor?